So in this section, we'll cover the regulation of growth hormone and the physiology associated with growth hormone release, and as a consequence, the pathophysiology of growth hormone dysregulation. So in this slide is a schematic showing the classic negative feedback for the growth hormone system. So GHRH is growth hormone releasing hormone, which is released from the hypothalamus, works on the pituitary gland to actually release growth hormone, and then growth hormone then works on the liver to release its target hormone called somatomedin. Somatomedin is currently called IGF-1 or insulin-like growth factor 1, but somatomedin was the old name, which refers to the mediator of growth. That's what somatomedin refers to. So release of IGF-1 from the liver then feeds back to both the pituitary and the hypothalamus, again forming the negative feedback system. Growth hormone itself has many effects. We talked about the effects on the liver with the release of IGF-1, but growth hormone also has direct effects, where growth hormone by itself can work on the fat cells to induce lipolysis. It can work in the muscle to build protein and also increase muscle size. And this is one of the reasons why elite athletes like to inject growth hormone, because it melts the fat and builds the muscle. But indirectly, growth hormone can also work on the bone through its action via IGF-1, and it enhances bone strength as well as the growth of bones. So growth hormone in general can have both direct and indirect effects depending on the site of its action. Again, as we said, when the physiology gets perturbed, growth hormone pathophysiology ensues, which can be manifested again as either a deficiency or an excess. So deficiency of growth hormone is usually manifested in childhood as dwarfism, and excessive growth hormone, again depending on whether it's manifested as in childhood or adulthood, can result in either gigantism, which is in kids, or a disease called acromegaly in adults. So let's consider a growth hormone deficiency first. So basic deficiency results in dwarfism. There are various kinds of dwarfism depending on the cause of the deficiency. So a simple defect in the somatotrope itself, and just the somatotrope, results in a defect in the growth hormone production. And that is a situation that leads to a syndrome called Lorraine dwarfism. And that's what's shown on the slide in the panel on the left. So compared to a normal child, a child with Lorraine dwarfism, where there's a isolated defect in growth hormone production, results in a proportionate child, well-proportionate child who is just short, has short stature, but there is no developmental delay or other developmental abnormalities. In contrast, if you have a child who has a global pituitary dysfunction, like a hypopituitarism but in a child, that results in a situation called a frolic dwarf, where there is global pituitary dysfunction, resulting in stunting of growth. There is arrested sexual development, lethargy, somnolence, and several other global pituitary dysfunction. And in this case is a lot more severe than just isolated growth hormone deficiency. Just to contrast the Lorraine dwarfism with Laron dwarfism, the problem in Laron is, like the Lorraine, short stature, but again, the defect is not because of a growth hormone production defect, but in fact, a growth hormone receptor defect. So in this case, the kids have plenty of growth hormone, but the growth hormone is not able to bind appropriately to its receptor, and hence resulting in a defective response. And that phenomenon is called Laron dwarfism. Moving on to the other end of the spectrum, where growth hormone excess is seen, again, if it's manifested in children, it's gigantism. And if it's manifested in adults, it's referred to as acromegaly. So in children, as you recall again, growth hormone helps work on the bone to not only make bone stronger, but also in kids, it actually makes the long bones grow. And especially when there's too much of the growth hormone and the long bones are growing before the epiphyseal plates are fused, then that results in a large skeleton, and therefore results in gigantism. And this process then can ensue in adults, and in this case, it is referred to as acromegaly. But also, acromegaly just also refers to the disease where growth hormone excess is first detected as adults. And this is the manifestation of acromegaly as shown in this slide. So again, growth hormone excess in adults is usually less subtle because bones have already fused and the skeleton is already formed, but there's lots of soft tissue changes and other internal and metabolic changes that happen as a result of long-term exposure to excessive growth hormone. So for example, from a morphological standpoint, excessive growth hormone can result in large and widely spaced teeth. It can result in coarse facial features, referred to as frontal bossing, protruding chin. It can result in large hands and big feet, and so often patients come in complaining about rings not fitting in or shoe sizes that are getting bigger. Again, from a metabolic standpoint, excessive growth hormone can even lead to diabetes from a long-term perspective. It can lead to hypertension because of cardiomegaly and left ventricular hypertrophy. And so excessive growth hormone is something that we should obviously pay attention to because of its long-term consequences. But it does require a high degree of suspicion to actually make the diagnosis from a clinical standpoint, because the changes are sometimes subtle and they take a long time to actually manifest, as shown in this slide. So again, represented in a schematic form is shown a man who is progressing through acromegaly over a course of over 20 years. As you can see, the features, especially the morphological features, take a long time to get manifested. And oftentimes these people have complaints of headaches and loss of peripheral vision, and this is largely because the pituitary adenoma is really the cause for this. If you recall, the pituitary sits in the sella turcica and is right adjacent to the optic chiasm. Optic chiasm is the place where the optic fibers cross, and therefore a compression of the optic chiasm leads to a classical visual field defect referred to as bitemporal hemianopsia. So if you see a patient generally with this type of presentation, with bitemporal hemianopsia, headache, it is usually referring to a pituitary adenoma. And a pituitary MRI will, of course, confirm this finding, as shown in this slide on the right panel, where you have an MRI that's showing a large tumor that's abutting the optic chiasm, therefore resulting in compression of the optic fibers, and therefore bitemporal hemianopsia. The diagnosis is largely clinical, as shown in this slide, and in the right clinical circumstance, the diagnosis is pretty straightforward. Because growth hormone secretion is so erratic, especially subject to diurnal variation, it's important to note that the diagnosis is not made by measuring random growth hormone levels, because growth hormone levels can be very high in the morning and very low in the evening, and that's a normal physiological change. So random growth hormone levels are not useful for making diagnosis of growth hormone excess. Instead, what's very useful is to measure random plasma IGF-1 levels. So plasma IGF-1, if you recall again, is one of the hormones that's secreted in response to growth hormone release. So it's a hormone that's pretty stable, doesn't have any diurnal variation, and so if IGF-1 is measured during the morning or in the evening, it stays the same, and it's usually elevated quite significantly in people with acromegaly. Sometimes it is often helpful to use growth hormone, but only in the setting of a dynamic test, like a glucose tolerance test, as shown in the right panel. So if you were to measure growth hormone directly, then it's best measured in the setting of an oral glucose tolerance test. So again, if you recall, growth hormone is very important for gluconeogenesis. right? Production of glucose. So we take advantage of the negative feedback system to elicit a response. So when you give a glucose load to a normal person, that excessive glucose actually suppresses growth hormone because of negative feedback. And again, as shown here in the blue line, you get a flat response to growth hormone when you give glucose. But when you have somebody with acromegaly, where they have growth hormone excess, then giving a glucose load is unable to actually suppress this normal physiological response, and then they continue to have increasing growth hormone despite the presence of glucose. So that would really be a very strong indication that someone really has growth hormone excess, because normally glucose should be suppressing growth hormone. But in a pathophysiological situation like acromegaly, glucose is unable to suppress growth hormone. Treatment is usually surgical because the most common cause for acromegaly is a pituitary tumor, and so surgery is the best treatment modality to remove that tumor. But oftentimes surgery by itself may not be sufficient. An adjunctive therapy is necessary, and both radiation and or medical therapy can be used. In terms of medical therapy, somatostatin is being used widely. And again, if you recall, somatostatin is a hormone that actually inhibits growth hormone, but also inhibits several other hormones as well. And more recently, there has been recent developments such that we can actually use a growth hormone receptor antagonist, where we can block the action of growth hormone receptor directly. So any one of these medical therapies, along with radiation as an adjunctive therapy, can be used after surgery to help control growth hormone levels. Our section on growth hormone physiology and pathophysiology. The main things to remember is that growth hormone is produced from the anterior pituitary and releases IGF-1 from the liver. And then this hormone system, again, has classical negative feedback, where growth hormone works on IGF-1, and IGF-1 then feeds back to the pituitary and the hypothalamus to shut the production down. Pathophysiologically, you can have either growth hormone deficiency or excess. And in terms of the deficiency, it's important to recognize the cause for it, either production defects or a response defect. And in terms of the excess, the main manifestation in adults is called acromegaly. And the treatment for acromegaly is mostly surgical. And in the next section, we cover in detail the thyroid axis and discuss both the physiology of thyroid hormone as well as the pathophysiology of thyroid hormone.